and welcome to Doc Talk Austin, Austin's home for medical news and tips.
Big sports injury that I see from football, soccer, basketball, skiing, just about any type of acceleration, deceleration sport is a tear in the anterior cruciate ligament, or ACL.
I'm your host, Deanna Brochin. Our first segment is with Dr. John Pearce, recognized by Austin Monthly Magazine as one of Austin's best doctors. Dr. Pearce will guide us through the most common knee injuries and surgeries.
I'm John Pearce. I practice general orthopedics at Austin Surgical Hospital. I have a special training in sports injuries, total joint replacements, lower extremity reconstruction. And what I was going to talk about today was with the knee, and this is a right knee. And what I end up doing is just taking the kneecap out of the place, and we can look inside, and then we'll talk about general injuries to the knee. This is the femur or the thigh bone. The leg bone, the tibia down here, and then to the side is the fibula. It's a smaller bone to the outside. And if you look inside the knee, there's two types of cartilage inside the knee. There's cartilage on the end of the bone called articular cartilage. It protects the end of the bone and decreases the friction in the joint. And then if you look in the center of the knee, you have your anterior cruciate ligament, or ACL, and then your posterior cruciate ligament, or your PCL. And the other big sports injury that I see from football, soccer, basketball, skiing, just about any type of acceleration, deceleration sport is a tear of the anterior cruciate ligament, or ACL. And what will happen there, it's still a twisting type activity, but you twist the knee to a point where that just tears the ligament. Actually, the femur will fall back behind the tibia and actually tear the ligament. You may have associated tears with those, such as a tear of the medial collateral ligament or the lateral collateral ligament, but the main injury is to the anterior cruciate ligament. Now, when the anterior cruciate ligament tears, it looks like the end of an old mop. It's just a bunch of filaments, so you can't repair that. You have to replace it with something. So what we usually end up doing is replacing the anterior cruciate ligament with either the patella tendon here in front, or there's two hamstring tendons that attach here. We can use those to reconstruct it, or we can take a cadaver tendon off a cadaver and reconstruct it with that. And that's done by arthroscoping the knee as well. You take out the anterior cruciate ligament, what's there, and you end up drilling a hole in the tibia here where it comes out into the joint right there. And then you drill another hole in the femur way in the back. So you have two holes in the bone, and we pass whatever we're reconstructing the ligament with through there. It's usually a very good operation. It stabilizes the knee again, but it does take an athlete 6 months to a year to get back to their sport, to their acceleration, deceleration sport. The graft has to mature, plus they have to get their muscle strength back. I see a lot of people, a lot of different ages, and a lot of my athletes that I've seen over years, just with the injuries to their knees, they start injuring this articular cartilage. What we can do, if everything else fails, injections, medication, therapy, is we can replace the joint. And a lot of people have when you talk about a total knee replacement, they feel that you're going to cut the bone here, and just put a machine in. It's not really that. What we end up doing is just making a series of cuts that just remove the articular cartilage. We do take out the anterior cruciate ligament, but almost always your medial collateral ligament, lateral collateral ligament, and the posterior cruciate ligament are still intact. We do take out the menisci, and then we just resurface the knee. So if you look at a knee that's been resurfaced, this is just a plexiglass of a knee that's in place. This is an actual total knee. You can see by the end of the femur, what we've done is just resurfaced the end of the femur. We've taken off the articular cartilage and put a metal prosthesis on the end of the femur. And then on the tibia, we have taken the meniscus out and just cut off the articular cartilage and put a metal prosthesis in the tibia. And then the plastic, or polyethylene, it's a real high dense polyethylene, and that's how you retense the ligaments. You can have different sizes of the polyethylene, and so you can put the ligaments back where they need to be and tense them. And then if they have enough arthritis in the back of the kneecap, we'll do a shave down the back of the kneecap and put a polyethylene component on the back of it. And so you still have your quadriceps tendon, your patella tendon, you still have your medial collateral ligament, lateral collateral ligament, and most of the time your posterior cruciate ligament. So your muscles are the ones that are moving the knee. So it's not a machine in there, it's really just a resurfacing of the knee joint. Now, once again, people are, this is not an outpatient procedure. People are usually in the hospital somewhere between 2 and 4 nights. Everybody has different needs in the hospital and different pain management. But this also is an operation that has gotten a lot better. The design of the implants has markedly improved from the years when we first started doing this. Anesthesia is markedly improved. People usually have a block, a femoral nerve block, sciatic nerve block, or they have an epidural to really help control the pain afterwards. And when you have pain control, you can start working on your motion and really start working on the road to recovery. Now, I do tell people it does take them probably a year to get over the operation, a year to where you're not thinking about it. Most of these patients are walking around pretty normally in about 3 or 4 weeks, but it does take about a year to get your muscle strength back, to really get back on doing everything you want to do with your knee.